Good morning, everyone. My topic for today is the magnitude of primary open-angle glaucoma in patients with obstructive sleep apnea syndrome. It is an observational study. There is no financial interest. So to start with, what is OSAS? It is characterized by repeated episodes of partial or complete obstruction, upper airway obstruction during the sleep, interrupting or reducing the flow of air, followed by transient awakenings, which will again restore the upper airway permeability. So these cycles of apnea and hypopnea are repeated several times every hour, which will produce a very impaired sleep cycle. OSAS has a huge negative impact on the health and lifestyle of adolescents, and it's an independent risk factor for many cardiovascular incidents as well. It is second only to bronchial asthma in the respiratory disease load of our country. On the other hand, glaucoma is also an optic neuropathy, which will cause tissue damage at the level of retinal ganglion cells in the optic nerve head. Thereby, it will create alteration in the structure and appearance of the optic disc, as well as severe visual field disturbances. It is a subset of the glaucoma where there is a normal appearing anterior chamber angle, which is open, and it may or may not be accompanied by raised IOP as well. So what is the pathophysiology in OSAS patients that will cause glaucoma? It is basically threefold. Most predominantly is the hypoxia factor, which will cause severe oxidative stress and inflammation and mitochondrial dysfunctions in the retinal ganglion cells, leading to glaucoma. Secondarily, these are the vascular dysfunction factors, which will lead to sympathetic activity, vascular dysregulation, increase of ICP and IOP, and it will cause glaucoma. Thirdly, some factors like obesity and supine positions also play a role, which will increase the IOP. So what is the aim of our study? Glaucoma is the third highest cause of blindness in a huge country like ours. And the presentation of this monstrous disease is often silent and symptomless. So if we can establish a positive correlation between OSAS and POAG, it will help us in screening and early diagnosis of this deadly disease. This is an observational study which was carried out jointly by both departments of ophthalmology and pulmonary medicine in the tertiary care center. Over a period of 1 year, 72 patients were first diagnosed as OSAS, admitted under pulmonary medicine, and subsequently evaluated for POAG. These patients presented to us with symptoms of loud snoring, nocturnal awakening, choking. Some had nocturia, some had excessive daytime somnolence, unrefreshing sleeps, and they presented with signs like obesity, increased neck size. Some had hypothyroidism and acromegalic features as well. We performed overnight polysomnography and transcutaneous finger oximetry in these patients to diagnose OSAS. The severity of these patients were then graded according to the AHI score per hour. Apnea here is defined as the complete cessation of oronasal flow for 10 seconds or more, whereas hypopnea is the partial reduction of the oronasal flow of 50% or more. So most of the studies said that if AHI is more than 5%, we can establish the patient as an OSA patient. This is then further classified between mild, moderate, and severe OSA as well. Another scale to see apart from AHI is the Epworth Sleepiness Scale, which is also an important screening test for OSA. Now, subsequently, once these patients were diagnosed as OSA, then we performed the ophthalmological examinations of them. Namely, visual acuity was tested by the Snellen's chart. Slit lamp examination was done to see for the anterior chamber depth. Corneal pachymetry was done. Apprenation tonometry was done. Gonioscopy was done with a Goldman 2-mirror gonioscope. Then we had the fundus and detailed disc evaluation with a 78D Vauquelin and direct ophthalmoscope. And finally, we did a perimetry with HFA 24-2 threshold to see for the visual field defects. So first a proposal was made, ethical clearance was taken, all patients of OSA were diagnosed, consent was taken from them. Then we had done tests for the ocular findings. After that, once they were established as POAG, then we had the charting of data. So what are the results? Out of all the 72 cases of OSA, 9 cases were found to have POAP, which comes to a whopping amount of 12.25%, whereas in the normal population, the incidence is only 2%. So as per the OSA grade, 8 out of our 26 cases fell in the severe grade of OSA. If we take them according to the EPSS scale, then most of our patients fell into the very sleepy or dangerously sleepy categories of OSA. In our study, we also found that prevalence of POAG was most among smokers, dyslipidemics, hypertensive diabetics, and some hypothyroid patients. So here this figure shows that the prevalence of glaucoma in the sleep apnea patients was 12.25. which is also in correspondence to previous studies by Karakusu, who had also shown that their incidence was 12.9. In some studies, the prevalence was almost as high, up to 27% too. Here we see the second figure, distribution of POAG according to different grades of OSA. If we take them according to the AHI scale, we see that maximum of our patients fell into the severe OSA category. That is 7 out of 27 of our cases. This is also in tandem with the previous studies done by Hashim et al. So it shows that more severe is the OSA, more likely is a patient to be diagnosed with POAG. And the figure here shows the distribution of POAG in accordance with the EPSS group, which, as mentioned before, our maximum of patients fell into the very sleepy or the dangerously sleepy categories. Here we see the distribution of POAG cases in our study according to the different risk factor groups. So we see that out of the maximum of our patients, there were 23 smokers. So smoking is a very, very important modifiable risk factor that can lead to POAG. Previous studies by Wise, Can, Bonovas, Kyotoju also showed that smoking is a very important risk factor. It causes vasoconstriction and elevated episteral venous pressure, which will lead to increased IOP. Other important risk factors that we found to increase POAG was CVA, stroke, which caused ischemic changes to the optic disc. Dyslipidemia and hypertensive changes caused a compromised peripheral vascular capacity and damaged autoregulation. And hypothyroid patients were also at an increased risk to develop POAG because of the hyaluronic acid deposition in the trabecular network. So when we treat hypothyroidism, it is also found that the incidence of POAG or the IOP subsequently lowers after treatment. So to conclude, OSA is a major risk factor for developing glaucoma. There's a high prevalence of POAG in the OSAS group as compared to the general population. Higher the grade of OSS, more the propensity for development of POAG. The percentage of development of POAG is much more in the very sleepy and the dangerously sleepy grades of EPSS, and smoking, stroke, hyperlipidemia, hypertension, hypothyroidism, diabetes are possible risk factors for development of POAG. Thank you.
Thank you, Dr. Sushmita. I think I must remind you that you exceeded your time, even though you tried to do quite a lot in a short time. So that's okay. Yeah, that's okay. The question I have for you is, do you do in your practice, in your hospital or institution, do you do a sleep study in all your glaucoma patients?
No, this was actually, we did the study to establish the correlation actually.
So my question, do you do it in all your glaucoma patients in your hospital?
No, we do not.
When would you do it in your routine practice? When would you do it in real life?
In real life, if we see that there is a patient of glaucoma and the patient has also these associated comorbidities that will also lead to OSAs, then we would probably, like if the patient is obese, if the patient has cardiovascular risk factors, then probably we would ask the patient to do OSAs, a study for OSAs. Also, doing the study, we learned these scales of EPSS and AHI when we were doing the questionnaires. So we learned that we can also present ourselves.
Is it enough to do just a questionnaire for sleep evaluation?
No, sir, but it is better than not doing anything. It will at least help us to screen mildly if the patient has OSA. Once we find that the patient is at risk of developing OSA, we'll refer it to pulmonary medicine for a proper polysomnography.
I request the other panelists to...
I wanted to know any relationship of duration of OSA but I wanted to know with the duration.
Could you repeat the question, Professor Mana? I think you went off for some time.
Okay, I wanted to know that was there any relationship of duration of OSAS with the development of glaucoma?
No, sir.
Presented.
Yes, I'm sorry, I could not establish the relation of the duration because in the questionnaire that we took, we did not have the column for duration. We had columns for symptoms, how it affects the lifestyle, but for what period of time, that was not we did not categorize it. So that was one parameter that was left out.
Dr.
We could
Sushmita.
not find the column. Yes, sir. Good morning, sir.
Good morning. OSA is cured or relieved by CPAP or BPAP, what we give. Then does it have, after using those appliances, does it have any effect on the glaucoma?
I could not gather significant data because we did in all 72 of the patients we did not follow up the case. Maximum were lost to us on follow up. But like of the few that we did after the CPAP treatment that they underwent and reduction of weight, then we followed up some patients, and in some of them we found that there was a reduction of IOP to some extent, not a significant. But I cannot establish the relationships. All 72 of them did not turn up for follow ups, so we did not document that. It is still pertaining to further study.